it's my pleasure to introduce Dr. Tremmel. She's an interventional cardiologist, and she's director of the Women's Heart Health at Stanford. And she will be speaking about the impact of negative emotions on the heart.
Okay, so thank you very much. It's my pleasure to be here, and I hear we're filming in HD, and so I was thinking I might run over to facial rejuvenation, actually. So we're going to talk about the impact of negative emotions on your heart, and most of this talk is probably going to be really depressing, but we'll try to throw a little bit of fun in it along the way. I think one of the first things I want to say is do a little disclaimer. So as you heard, I'm a cardiologist, and I'm not a psychiatrist, and so this is going to be coming to you from a particular perspective, and I think a lot of this comes from my background. So while I'm a cardiologist, my major back in college was psychology. And I was very interested in psychology. And my favorite class in all of college, I think my most influential class was one on health psychology. And we talked about how the mind and the body were connected, and that people's emotional things affected their physical things, and how they were doing physically affected them emotionally. And I was like, wow, that really makes a lot of sense. And it always stuck with me. And it was one of the things that I think a lot of physicians never got that message, and they didn't take that class. They were taking biology or physics or whatever, which I had to take as well. But I think it's something that a lot of physicians don't quite grasp, and certainly if they're not psychiatrists. And ultimately, there's this melding here of the brain and the heart, and bringing this together. And this takes physicians from both fields, and it's not just a cardiologist who's going to be able to come up with all the answers for this, or just a psychiatrist. And another problem that we have in this is that our disciplines are different. We publish in different journals. There's not always a lot of communication, and so that's something that we're trying to bring together here at Stanford. So just a brief overview to get everybody up to speed on cardiology. So I do research in sex differences and have a focus on women's heart health as well. And we have all women, I think, in our group, well, almost, few men. So cardiovascular disease is the leading cause of death in women as well as men. And 1 in 4 deaths in women are attributable to coronary artery disease, and 1 in 2 deaths to all forms of cardiovascular disease combined. And heart disease isn't just a disease of older people. It's the second leading cause of death for women 45 to 64, and the third leading cause of death for women 25 to 44. And we know that it kills more than 500,000 women per year, and it kills 6 times as many women as breast cancer, and it kills almost twice as many women as all forms of cancer combined. Okay, so heart disease is a really big deal, and it impacts all of you significantly. And we know that more women than men are dying of cardiovascular disease, and this has been going on every year since 1984, and that we have a gap between the sexes in terms of mortality and death, and this gap got quite large here, and the gap is narrowing, but we still have this gap, and these gaps are what I'm very interested in reducing and getting rid of. And so whenever we see these differences in cardiovascular disease, this is something that I want to figure out, why do we have that? How do we fix it? So, and when we think about who gets cardiovascular disease, there are traditional cardiac risk factors that we look for in everyone. And so we want to know, how old is this person, and are they at risk? So if you're over the age of 55 as a woman, we think you're at risk for heart disease, and your risk goes up as you get older. If you have diabetes, if you have high blood pressure, smoke cigarettes, high cholesterol, you're overweight, you have a sedentary lifestyle, or you have a family history of heart disease. And these are the traditional cardiac risk factors. These are things that we typically know are an issue. But what about negative emotions? And so there's reams and reams and reams of data about negative emotions, yet this is a very difficult topic. So we do know that several negative emotions have been associated with developing subsequent coronary heart disease. And we also know that people who have coronary heart disease and have negative emotions at the same time have a worse outcome than people who have heart disease but don't have negative emotions. But this area is actually very difficult, and I think one of the things I want to make sure you all walk away with today is that it's not totally straightforward, and it is a complicated topic. And I think part of it is that it can be challenging even to define what are negative emotions, and then it can be challenging to measure those as well. And then are these emotions that we're talking about, are they acute emotions? Are they chronic emotions? And how does that affect people differently? And if we think about some of the classics, so depression and anxiety, I would say have gotten the most attention, and then stress, anger, and hostility. So depression, so are we simply talking about somebody who has a low mood, or are we talking about someone who's suicidal? Big difference, right? If anxiety, are we talking about someone who kind of worries a lot, or somebody who's out there having panic attacks? Stress, what does stress mean? Does that mean that you got stuck in traffic and you're stressed out, or has something really tragic just happened and you're stressed out? Anger, how do you define anger? What about a person who doesn't really express their anger? Are they less angry than someone who does express their anger? And hostility, does this mean that that's somebody who just yells at other people, or is this somebody who's shooting other people, right? So these can be very hard to define. I think stress is probably the one we all think of the most, and it's probably the hardest to define of all of these. So we're going to go through most of these today and kind of talk about what we know in terms of their effect on heart disease. So there are certain things that happen when we're stressed in the cardiovascular system that are functional, that we want to have happen. And everybody knows this. If a lion's chasing you, you want your body to rev up so that you can run away from the lion successfully. The issue is when these responses occur out of proportion to the stressor that's happening. So it's not a lion chasing you, it's someone who cut you off in traffic, right? Or if it continues after the stressor has ended, so that person cut you off in traffic, and 6 hours later you're still like, God, that person cut me off in traffic, right? That's a problem as well. So this is when we have these things going on, yet the stressor is not really there anymore. So studies of negative emotions and heart disease have consistently shown that there's a dose-response relationship, which means that it's not simply at some particular point of that you've achieved depression that's going to give you heart disease, or you've achieved a certain level of anxiety that gives you heart disease. A little bit of depression is not as healthy as none. Having a moderate amount is a little worse than having a small amount, et cetera. So there's not a threshold, it's more of a dose-response relationship. And so this means that people that even have subclinical levels of symptoms might still be at increased risk. And probably most of you in the room, this is more what we're talking about, unless everybody here has major psychosis. I don't know, that may be possible as well. But probably, we'll see, everybody's gonna go blah all of a sudden. But this is really what a lot of us are concerned with, is what about these things that when we don't feel happy with our lives, or we're feeling stressed in our lives. So just a little bit about the prevalence. So these things are very common, and they're more common in women than they are in men. And so the lifetime prevalence of depression in women ranges anywhere from about 9 to 21%, and the lifetime prevalence of anxiety, 8 to 16%. I'm sorry, these are of both sexes, this range. And then women are significantly more likely to be diagnosed with depression and anxiety than are men. And you can see it's at least twice as much that women will have these sorts of negative emotions compared to men. Hopefully you can kind of see this, but this is a breakdown by state of having current depression, a lifetime diagnosis of depression, and a lifetime diagnosis of anxiety. And so the white states are states that don't have any data regarding them. And then as you go up in kind of darkness of blue, the lightest blue ones, like Iowa, which is where I'm from, less than 6%, and then 6 to 8%, and then 8 to 10 to 12, and then these dark ones greater than 12%. And we can just kind of look at California because we all like to look at ourselves. So current depression in California, 8 to 10%. Lifetime diagnosis of depression in California, 13 to 15%. And then lifetime diagnosis of anxiety is less than 10%. And we know that depression is particularly common after a cardiac event, like a heart attack. And particularly for younger women. So it's more common in women, and then if you look by age, even more common in young women. So these light gray bars are women, the dark bars are men. This is under the age of 60 and over the age of 60. And if you think you're going blind, these are actually blurry, just so you know. And so you can see here, women always greater than men in terms of having depression after a heart attack, and younger women particularly more than the men and even older women. So again, if you look at women who already have heart disease, these negative emotions are quite common. So women with cardiovascular disease, depression ranging up to upwards of 40%, panic disorders 10 to 15%, having elevated levels of anxiety, again, almost 40%, and insomnia, very common. And I'm not sure if this is really a negative emotion, but it's something that I've added here because our clinic has started to look at these sort of things, and we've hired a psychologist in our clinic who's an insomnia specialist, and insomnia certainly is related to these negative emotions as well. And so we've started to look in our clinic. So we have a clinic, a women's heart health clinic, and we have women who come in with a full range of issues, and they may just have some risk factors they're worried about. They may have just had a quadruple bypass. So there's a range of women in the clinic. But if we look at them, we actually find that our clinic has about 21% depression, 18% panic disorder, 23% with elevated levels of anxiety, and 53% insomnia. And 20% of them are having moderate to severe insomnia. So there's quite a bit of negative emotions in my clinic. So that's probably not a good thing to say, but people don't seem to be too happy. So this is something that needs to be addressed, right? So the other thing that we know about people who have depression, not only do they have more cardiovascular disease, but they often have a lot more cardiac risk factors. And so this is the overall population and the percentage of depression that we would see, and anxiety, lifetime depression. I'm sorry, this is the overall population who not necessarily having depression or anxiety. This is lifetime diagnosis of anxiety, lifetime diagnosis of depression, and then current depression. And so you can see these higher rates of cardiovascular disease in the overall population, but also diabetes, smoking, inactivity, extra drinking, that sort of thing. And so this is actually going to come up as we talk today about the role of cardiac risk factors as well, and the interplay of cardiac risk factors with depression or these other negative emotions and heart disease. So I wanted to start and talk about stress and really talk about acute stress, and we're going to just make a couple of points about acute negative emotions, and then we can go on and talk about chronic a little bit. And acute stress is very interesting in terms of studying, I think, and most of the studies that people have done have been around natural disasters like earthquakes or something, and that they've seen that cardiac events have this spike after something big happens in the world. And they've mostly looked at people who already have heart disease. And this particular study looked at 9/11, which we all know was a very stressful event for all of us in this country. And what they did was they looked at what happened in the month before 9/11 and what happened in the months after 9/11 in patients who had defibrillators. And because they can, with the defibrillator, your defibrillator will go off and you'll get a shock if you have a bad heart rhythm, and that's recorded. And so you can actually look at how many times do people's defibrillators go off before 9/11 and how much after 9/11. And they found this significant spike in the month following 9/11 of people's defibrillators going off, which means that there are more lethal arrhythmias that were occurring during that time than there were before 9/11. And this is pretty classic that we'd see this. So the earthquake or something like that, same sort of thing, that there's suddenly more heart attacks, more bad rhythms, that sort of thing that are occurring. And interestingly, none of these people were right there or something like that. They were like most of us, so we saw it on TV, yet were very profoundly affected. The other kind of classic acute stressor that we see in cardiology is this phenomenon called Tako-tsubo, which is a Japanese name based on the way the heart ventricle looks in patients who present with this. And what this is a transient kind of failing of the heart muscle. And it occurs in people who have just had some sort of acute stressor, and it's predominantly women and predominantly postmenopausal women, almost over 90% postmenopausal women. We don't know why, but they have some sort of acute stressor. It's usually negative, but it can be positive. There have been reports of having a surprise birthday party, for example, and that sets this off. So it's not always something bad. And what happens is these patients come in and they look like they're having a heart attack. They're usually having chest pain. They may be having some shortness of breath. They'll have changes on their EKG that look like they're having a heart attack. We'll take them to the cath lab and we'll look in their arteries. They'll have an angiogram and their arteries will look perfectly normal. And so then it's a heart attack. They wouldn't have normal looking arteries. And then we look at their ventricle, which is the pumping chamber. And normally the pumping chamber, when it relaxes, looks like this. And then when it contracts, it squeezes like that. And there's a normal kind of squeezing of the whole ventricle to squirt the blood out. With this Tako-tsubo phenomenon, the ventricle kind of is a little bit rounder like this, and then what happens is it squeezes here at the base, but this part balloons out, right? And so it's not all squeezing like this part's not working, basically. And it looks like this thing called an octopus catcher, which is a Tako-tsubo in Japanese. That's the only Japanese word I know is Tako-tsubo. But it's a narrowed neck and then this big bowl, and I guess octopus get stuck in there. So if you see one of these, don't crawl in. This is what it looks like, and it's so patients can have heart failure with this because their heart's not pumping very well. They could have bad arrhythmias with it. They could have sudden death with it. Most patients, you just support them, and about a week later, it all goes away. It's gone. So it's a strange phenomenon, and we don't understand a lot about it. And basically, in the United States, we kind of started to even understand it or identify it about 6 years ago or so. The Japanese were on top of it about 10 years before us. And it's probably been around forever. We just have finally realized what it is. So we're still learning a lot, but this is another kind of classic now thing that happens with acute stress that the heart's responding to. So we definitely know that the heart has some adverse things that it can do in times of acute stress. So, and we know that during acute stress, then you might not be getting enough blood flow to your heart muscle. Your arteries might constrict when you don't want them to. Your platelets might get more sticky, so you may be more prone to clotting. You might have more arrhythmias. But what happens if these things are kind of going on chronically and all the time? So the biggest thing is depression. I think that we'd see in the literature. There's lots of data about depression. And I just there's hundreds of studies, and I just pulled out one that had all women in it. So the Nurses' Health Study looked at 63,000 women, and these were healthy women to begin with, so they had no heart disease. About 8% of them had clinical depression. And what they found was these women who had depression were younger. They're more likely to have high blood pressure, diabetes, high cholesterol, tobacco use, excess weight, sedentary lifestyle, so all the risk factors that I listed before. But even when they took all of these things into account, they found that these depressed women were significantly more likely to have a heart disease-related death than women who weren't depressed. And so while all of these things relate to heart disease, they're not the only answer. And depression itself seems to have an influence in terms of having heart disease death as well. The other thing that this found is it looked at women who are on antidepressants versus those that weren't. And they found that women who are on antidepressants were significantly more likely to have sudden cardiac death. That's what this stands for here. So this is also a concerning finding, right? And what does that mean? So I think this study brought up several sorts of questions that are pretty common within the depression literature itself. And this whole idea of chicken or the egg, right? So which one's coming first? So one of the big questions is, did people get heart disease because they were depressed, or did they get depressed because they had heart disease? Right? I mean, that's a real question. And so that's one of the things we don't really know. It's hard to tell which way did it go. Did they get their risk factors because they had depression? So they're depressed, they sit around on their couch, and then they have high blood pressure and excess weight. Or did they get their depression because they had risk factors? Are they depressed because they're overweight and they have high blood pressure? Don't know which one. And then what about these people on antidepressants? Did these people on antidepressants have more severe depression, and that's why they had more sudden cardiac death? So was it simply a marker of more severe depression? Or did they have more sudden cardiac death because they were on an antidepressant? Did that antidepressant actually cause an arrhythmia in them? to relate to this. So I don't have the answers to these questions, but I present those to you so that you, again, can kind of understand the complexity of this whole issue of sorting out which comes first. So what about not women who have no disease to begin with, but what about those that already have heart disease at baseline? We know that if you have depression after you have your heart attack, you have a 2 to 2.5-fold increase of having a poor outcome. So if you're a woman who has a heart attack and you have depression at that time or develop it soon thereafter, you do not do as well as a woman who doesn't get depression in that time. Multiple studies, again, these sorts of analyses, when we show you this, are just listing all these different studies, and there's basically a line, and they say, is there an association between cardiovascular death and depression, or is there not? And if the dot falls on this side of the line, basically there is an association. So what we see is there's an association between depression and cardiovascular death in people who have just had a heart attack, and similarly having future cardiovascular events in people who have depression. 5 minutes, we're never gonna get through. I haven't even got to the fun part yet. Okay, so I guess I should talk faster. So anxiety, now I'm gonna have all of this anxiety. So anxiety, again, these can be hard to define. It's an emotional response to a situation that's perceived to you as uncontrollable or unavoidable. And it's associated with feelings and physical symptoms. And so some of the feelings might be fear, worry, uneasiness, or dread. And the physical symptoms are many that can come up: heart palpitations, muscle weakness and tension, fatigue, nausea, chest pain, shortness of breath, stomach aches, or headaches. And this is an interesting list and one to make note of, because a lot of these symptoms sound a lot like heart symptoms, right? And so this is a very confusing thing for people. And making it more confusing is that you can have these symptoms without an identifiable trigger. So you don't have to have something suddenly happen to you and then you have these sort of symptoms to say that it's anxiety. So you could have anxiety, nothing happened to you. And that's very hard to sort out then, is, am I having a heart event or am I having anxiety? And a lot of people don't know, and we spend a lot of time trying to sort that out. So similar to depression, having anxiety is associated with heart disease. Again, from the Nurses' Health Study, women who didn't have any cardiovascular disease, they found that those with increasing anxiety had more fatal cardiac heart disease and, again, sudden cardiac death. And we've seen similar effects in men as well. So hostility and anger. So the original research on this area was the type A behavior, and you might have heard about this and read about this. And the type A behavior was defined as hostility, intense ambition, competitive drive, constant preoccupation with deadlines, and a sense of time urgency. But ultimately, they failed to find an association between type A personality and heart disease. And so then researchers started to focus on components of that, and particularly they were interested in hostility and anger. And so hostility is having a negative attitude or cognitive trait directed towards others, whereas anger is more feelings. So anger is our feelings, actually, that vary in intensity, and these can be from mild irritation or annoyance to an intense fury or rage. And these people often have an aggressiveness that can be verbal or physical and may manifest as yelling, intimidating, or even physically assaulting people. So hostility and anger, we see a similar thing. If we take a healthy population, this is associated with an increased heart disease rate, and this association actually may be stronger in men than women. And if you take patients who already have heart disease, their prognosis is poorer than those who don't have anger or hostility. Again, certain risk factors will play a role in this and kind of lessen this association, but they don't get rid of it completely. And then just a brief slide on insomnia. So if we look at insomnia, again, that can be difficult to define. In this particular study, which was actually quite a bit of women, which just shows you that a lot of women have insomnia, because if you look at most studies, we're lucky if we have 50% women, and we automatically had 62% women in this study. This is a shorter duration of sleep was considered less than 7.5 hours. The other factor that they looked at is what happened to women's blood pressure, or men too, but what happened to blood pressure at night. And at night, when you go to sleep, your blood pressure should drop about 10 to 20% lower than what you have during the day. But there are some people whose blood pressure stays basically the same all the time, or might even get a little bit higher. And there's several reasons this might happen, and it may be that you're just not sleeping well, or that you're restless during your sleep, or that you have some sort of sleep apnea. But patients who did not have their blood pressure drop at night did worse. And so what they saw was those who have a normal drop in their blood pressure at night, there really wasn't much difference if you got less than 7.5 hours of sleep or more. But if you did maintain this normal blood pressure at night, which would be abnormal, then these are the ones who had less than 7.5 hours compared to those who got more. So the combination of having not enough sleep and having insomnia, and then not having your blood pressure drop at night was certainly a bad combination in terms of developing cardiovascular disease. So lots of mechanisms have been described that might be causing this, and some of them are direct effects on the heart, and then some of them are indirect effects. And so direct effects would be, your sympathetic nervous system's revved up from your negative emotion, and so your heart rate's up, your blood pressure's up. We mentioned some of these things. You have more inflammation, clotting, etc. Maybe you don't sleep as well. This may be a direct effect. It may also be an indirect effect. More classic indirect effects would be because of your negative emotion, you're not exercising as much, you're eating more, you're smoking more, you're not taking your medications as prescribed. And it turns out that these sorts of things probably account for about 65% of the risk of developing heart disease. So if you look, another mechanism may be kind of our interaction with society, and how much social support do we have. And so this particular survey, which we did in our clinic, is how many people do you have near you that you can readily count on for real help in times of trouble or difficulty. And so at this side we have 10 or more, at this side we have 0. And then we have symptoms of depression. And so basically you can see high depression in those with low social support, and then it gets less depression with high social support. Now the question that should come to your mind right now is chicken or the egg? Right? So do these people have high depression because there's no one around, or is there no one around because they're depressed and nobody wants to be around with them? So it's hard to know which one, right? That's a real possibility. So we see this association with depression. We see it in our clinic with anxiety. We see it with stress, and we see it with insomnia. So this tells us at least something about having people around you may be a good thing. Now, just briefly, this is unfortunately kind of the way cardiologists deal with negative emotions in clinic. They just kind of try to ignore it. Maybe I can get my job done without talking about it or thinking about it. And it's unfortunate in a way. It comes about for a certain reason, I think. And so on the cardiologist's behalf, I would say, first of all, that cardiologists aren't necessarily well equipped to deal with negative emotions, so they haven't necessarily gotten the training that they need to detect it, or certainly not any training to treat it. And then time is a real issue, right? So we need to deal with your heart. Right? And then if we deal with your heart and then we ask you about how are you feeling, we may not have enough time to cover all of it. And I can tell you, asking someone how are you feeling can be opening up 30, 60 minutes of information. And while I think that's vital to know, a lot of people don't want to go there. The other thing is that the data hasn't been very strong for cardiologists to pursue this. And so in 2008, for example, it was said that in general, if you took all the data together, depression that's treated with medication or cognitive behavioral therapy in patients with cardiovascular disease is associated with a modest improvement in depressive symptoms, but no improvement in cardiac outcomes. So that doesn't bode well for cardiologists being very interested in identifying and treating depression if they don't think they can change your heart disease at all. So this is kind of how negative emotions are to me, right? So they're the elephant in the room. And it's the one thing that, we can circle around and we can do all the other stuff, but until we kind of address that, I don't really feel that we've taken care of the whole person. So there are a variety of therapies, and I certainly don't know how to do any of these therapies, but finding people available for our women in clinic to do this is key to me. And there are things ranging from having formal psychotherapy to cognitive behavioral therapy. There are medications, simply relaxation, meditation, biofeedback, mindfulness-based stress reduction, and regular exercise are all things that have been studied. And it's not that they're never beneficial, but I think we're still trying to figure out what's beneficial to whom and when, or to who and when, to whom. So here's an example of women having depression after an MI. And in this particular study, what they did was they had half the women in usual care, and the other half they tried an intervention that really dealt with stress and how to cope with stress. And they actually did find a reduction in mortality in these women who had this sort of therapy. So perhaps that women are more responsive than men to certain kind of therapies, or perhaps if we address stress as opposed to other things in depression, we can find something that's helpful. So I certainly don't think we should give up and say, oh, this is never helpful. I just think we haven't quite found the right answer. So I wanted to close on a positive note, and so just briefly about positive emotions. And this investigator, Kubzansky, has become my new favorite researcher because she does very exciting research on how do positive emotions affect your heart. And I just think that's the coolest thing, because everybody else thinks about negative emotions, right? So most studies look at the presence or absence of a negative emotions, but the absence of a negative emotion doesn't mean that you necessarily have presence of a positive emotion. And so we know that optimism cuts the risk of heart disease in half, so simply having that trait. And then she studies something called emotional vitality, which also appears to reduce the risk of heart disease. And this is kind of a gestalt of things, but it's a sense of positive energy, the ability to effectively regulate emotion and behavior, and positive well-being, which includes feeling of engagement and interest in life. It's having energy and pep. It's being happy and satisfied with your personal life and feeling emotionally stable and sure of yourself. And when she looked at emotional vitality, she found that there were fewer heart disease events and people had increased emotional vitality. And even after she controlled for risk factors, unhealthy behaviors, presence of depressive symptoms, all of these things. So these patients on top are those with the highest emotional vitality, and then medium, and then low. And this is a curve of survival. So less survival as your emotional vitality goes down, and no difference between women or men in this regard. The other thing that she's looked at is the ability to self-regulate. And this is, self-regulation is basically the ability to adjust or adapt when something comes at you. And so that you know what to do and you can change what you're doing. So it's not just repressing emotions, but you're flexible and you're resilient in doing this. And we see the same sort of thing, that those with low self-regulation have lower survival, and those with high self-regulation have higher survival. And I was talking to my nurse practitioner, and she told me she'd just gone to a talk by Benjamin Zander at The Art of Possibility. I don't know if you guys have heard of him. But apparently, if he messes up, he yells "Eureka," as if he's discovered something that now he can learn from. And to me, that's a real sort of ability to self-regulate, right? So something bad's happened, and you say, "Eureka!" And then you move on from that because you know that you should do something differently next time. So here's your key slide of the way to a happier and healthier life. Everything you wanted to know. So happier, healthier life. So having emotional vitality. So this is a sense of enthusiasm, hopefulness, and engagement in your life. Having optimism. So the perspective that good things will happen and that one's actions account for the good things that occur in their life. having supportive network of family and friends, as we talked about, and then being good at self-regulation. So it's bouncing back from stressful challenges and knowing that things will eventually look up again. It's also choosing healthy behaviors, such as being physically active and eating well, which is something I promote as a cardiologist all the time. And it's avoiding risky behaviors, so drinking too much or regularly overeating. And so in summary, from what we've talked today, we know that women have nearly twice as much depression and anxiety as men, although men may have more hostility and anger. We know that negative emotions are associated with the development of heart disease, and that those who have heart disease will tend to do worse if they have negative emotions after their event, and that the association is likely due to both direct effects and indirect effects, such as not taking care of yourself. And there are treatments out there, and they should be used whenever we can, and we certainly need to learn a lot more. And ultimately, people should try to develop positive emotions and healthy behaviors, which may lessen their risk of heart disease. So whenever you can, make sure that this is you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.